I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. In this episode of the NEI podcast, I have here with me some very special guests. We are getting a chance to answer some of your unaddressed questions from a phenomenal presentation that we had at our NEI Congress last year, 2022. We have here with us today Dr. Christine Moutier and Christopher and Martha Thomas, who are founders of the Defensive Line. Dr. Moutier is the Chief Medical Officer for the American Foundation for Suicide Prevention, or AFSP. Welcome to all three of our guests today as we discuss a look back at this incredible presentation that actually received a standing ovation. So welcome all of you to our show today.
Thanks, Sabrina.
Thank you very much, Sabrina.
So my first question is for the Thomases. Chris and Martha, what was your experience like taking the stage at the Neuroscience Education Institute? And how was this presentation different from others that you've given on this topic?
It was kind of intimidating to be in front of so many providers and researchers in the field. But we kind of told ourselves, that our experience, we're experts in our own experience. We're experts in our own story. So we kind of rode with that. It was a wonderful experience. And we were also well received that it was very moving.
Yeah, I agree with Martha 100%. I was intimidated initially because, you got, Dr. Stahl and Dr. Moutier, preeminent experts in the field. But they made it so much easier for us to share our story and to talk about the importance of, supporting people who are at risk, in particular, people of color, students of color, and just how important it is to have a discussion and tell our story. And I was just impressed that it impacted a lot of people, talented, bright people, and just the response of people coming back to us after asking us to come to their communities to talk about it was just great. The only thing that surprised me was somebody pushed back about, focus on race. And I think that just means we need to have a more thorough discussion about how race has an impact on mental health and why it's important to talk about it. I think the person just needed more information. But overall, it was just a phenomenal experience.
That's wonderful. Wonderful. Dr. Moutier, you recently received the Annual Scientific Research Award from NAMI. Your book, The Suicide Prevention Handbook, that you co-authored with Dr. Stephen Stahl, was also the winner for the 2022 category of psychiatry from the British Medical Association. What was it like when you got the news about those?
Well, it was just completely humbling, and both of them felt like a complete surprise. And, I think for myself, being somebody who is really just giving my life's work to suicide prevention, and so I'm all about the impact that myself and that relationships and partners with amazing people like you all, really, truly, each of you have been incredible partners in the work of suicide prevention and postvention. So for me, that's what this is all about. It's about impact and trying to produce some really deep, difficult, frankly, changes in the world. And that includes with the behavior of health systems and workplaces and schools and policy. So I think to have those 2 points of recognition, to me, it's like, yes, this could mean that more people are willing to take a look at how the research and the application of towards their own work, it might draw a little bit more attention to that. And so that's what it means to me, but, completely humbling to be in the service of all of that and to have that recognized.
That's wonderful. Now, the presentation that all of you gave with Dr. Stahl for the NEI Congress received a standing ovation from our audience, and we received so many excellent questions. And as you know, we didn't have time to address all of them. So let's take a look at some of the questions that you didn't have a chance to answer. Our first question for the Thomases is, do you currently have a relationship with the military or plan to do any training in suicide prevention through military services?
That's a very great question, particularly when you think about, there are about 22 to 23 veterans that die each day by suicide. And so far, we've been working with a couple organizations. One is TAP, and the other one is MVP, which is Merging Veterans Players, which we're working through with the NFLPA organization. And then Solomon, through the Jets, has been working with Wounded Warrior Project. In fact, they just did a recent piece on that for Veterans Day. And so those are the key areas we're focusing in on, as well as the great work the AFSP is doing. We want to support their work because that's where their key strategic planks is to work with veterans. So whenever we get a chance to do that, we'll support them in that effort. So, and obviously, the defensive line is trying to focus on working with leaders of young people, particularly young people of color. So where we can leverage, veterans who have impact there, and whether they have had athletic backgrounds or just military backgrounds, we're going to work with them to help spread the message of our D lines of, understanding the warning signs. So that'll be the key focus for the defensive line with veterans moving forward.
That's excellent.
We also got a lot of help from a few veterans setting our organization up. So that was really meaningful and powerful because they themselves had been touched by suicide so many times.
Mm-hmm. Yes.
The next question I have is for Dr. Moutier. Can you explain the public health model framework for suicide prevention in a bit more detail? I know you talked about this in your presentation. Why is universal prevention through programs in schools and communities important?
Well, one way to understand the application of the public health framework to the topic of suicide prevention is to think about the fact that suicide is a complex health behavior and a complex health outcome, a health issue. And so like any health issue, especially in the early phase of, really making that investment as a society to understand that health issue better through research, and then to apply all of those learnings into the public health framework. What that needs to look like is it will be a multi-tiered approach. And that's because an issue like suicide is complex. And so even if you fully applied the universal strategies, that means that every human being, ideally in a population, gets touched and shaped by the culture, by attitudes, by things that they're surrounded by in their school, basically where you live, learn, work, play, and worship, that all of those, if they were optimized, that would mean that every human being, and remember, suicide is a human issue, so anyone and everyone can become distressed, struggle, can have suicidal thoughts. Suicidal thoughts are very common in the general population. And what it would look like if we ideally and maximally applied the universal part of the public health framework of suicide prevention is that every human being and child would grow up in an environment where there's no stigma around those human experiences, and we're accessing support from peers, from family, from teachers, mentors, but also clinical support and treatment would be, utterly accessible for all. That's really the sort of utopia version of the universal towards suicide prevention. And then, of course, in the multi-tiered framework of the public health model, we also need to reach people upstream, and that's the universal approach, so that everyone is getting that same basic set of tools for coping. And, if you think about it this way, if you have family members in your own family who, let's say you have several who have died early from heart disease, you know that there are certain ways that you need to protect yourself and your children because of, genetic loading and other influences that might set you up for a little bit higher risk. Well, we don't, as a society, we haven't yet applied that same principle so that families and everyday people would be able to apply the same basic knowledge every human being in a society, imagine that, knowing what their particular vulnerabilities and strengths are. So again, so we think about upstream, midstream, and downstream. That's part of this public health framework. That means that upstream means prevention for everybody, setting us all up for optimal coping and access to care. The midstream approach means that people who already have been identified as having higher risk are going to get some extra support and treatment opportunities, whether they're support groups, education. It's not just all in the clinical world. It can mean in the community, family, and school and church context as well. And then the downstream moment means when people are becoming more acutely at risk for suicide. And that's things like the crisis response system. 988 would be part of that downstream application of suicide prevention. So that's a little bit more about the public health framework.
That's incredible. Such great information to share with us. Thank you. Our next question for the Thomases is, how do people get into contact with TDL to discuss scheduling a workshop?
So our email is info@thedefensiveline.org. And it's not up on our website or you can't get into us. We are not a crisis response organization, and we don't, as a young organization and a small organization, we don't have the ability right now to handle crisis response. So info@thedefensiveline.org is the best way.
And we will put that in the show notes.
Thank you.
The next question I have is for Dr. Moutier. What does safety planning look like on a practical level if a clinician were to implement this with a patient?
Okay, great. And safety planning is one of the most promising and growing evidence-based brief interventions that we have. And so it was developed by Barbara Stanley and Greg Brown as they were actually dealing with a research study of suicidal adolescents and really trying to find ways to make sure that they kept their research subjects safe during the experience of research. And lo and behold, it turned out to be a brief intervention of its own that warranted its own, research plan. And now again, they and others have been able to show that applying the safety plan to anybody who is identified as having any level of suicide risk can be effective. And so for clinicians to know, it is a skill set to learn. It is a very patient-centered approach where you empower the person to come up and collaboratively you work together with them to understand their triggers for what makes them become more suicidal or even a little bit earlier than suicidal thoughts, what creates a level of distress. And then so that's learning their own warning signs and triggers. And then once they are realizing, okay, now I'm in the moment where I'm being my risk and distress is being activated. What can I do? And so the first layer is, who are the people, or actually even before they get to people, they get to their own activities that can serve as distractors to their suicidal thoughts. So things like listening to music, taking a walk, but they're the experts of their own experience. So they know what works best for them in those moments. But by writing it down in the app or on the, written piece of paper, they learn how to use it and pull it out in those moments when they need it. And then the next step is to identify the people, social contacts. So these are friends, peers, maybe also family members, anyone in their life who agrees to be part of their safety plan to support them during that moment of, and really it can be, social contacts can be people who aren't clearly not mental health professionals, but just people who know how to be with them, listen to them, maybe even distract them by, talking about other things and drawing them out of that moment. The brain can do that, can shift modes when you're around certain people and certain influences. And then the next layer is coming up with the closer people, like family members and supports, who actually will talk to you and listen to you and support you in that moment. So it's less about distraction and more about really like caring and listening. And then the next layer in the safety plan are having your professional people and crisis resources ready to go so that if those other people aren't available, the individual still has, resources to call. So that could include things like 988 or the crisis text line. And then the last part of a safety plan is making the environment safe and secure from lethal means. And that's something that can be done certainly in the moment of crisis, but ideally is done even before they get to a real crisis moment. And I would really just encourage every clinician to not shy away from conversations with patients about lethal means in the home environment. Even though in our country we have this polarized, issue around firearms, that is not a reason to not approach it and to be caring and supportive and open-minded and asking the patient about what lethal means are in their environment and how can we work together and maybe work with family members as well to make the home environment safe and secure from those lethal means. And there's a whole training called CALM, C-A-L-M, that can help clinicians learn how to have those conversations about lethal means in a way that's more, confident and sophisticated. And there's also training for this entire safety planning intervention, most definitely. The Suicide Prevention Resource Center has resources on the safety plan. And actually, Barbara Stanley and Greg Brown also have trainings, and we at AFSP support those.
That's excellent. And I believe that safety planning is a large component of the workshops for the defensive line. Is that correct?
Yeah, we do talk about the importance of supporting and recognizing the warning signs of somebody who's at risk and somebody who, a leader of a young person, might need to intervene and make sure that they get the resources and support they need to, keep themselves safe and out of harm's way.
That's excellent. So my next question is for the Thomases, and someone asks, how can they set up a university presentation from the defensive line?
So they can email us as well at either at info@the-defensive line, and then we would go from there and work on planning and setting up a time, who they could, who would actually attend. And my email is Martha@the-defensive-line and Chris.org, and Chris is Chris@the-defensive-line.org.
And the other thing I'd like to add on to that is sort of how you get into getting us to a presentation at the university. I think it's important to also talk about, what we do and why it's important. And what we do, as you just mentioned, talk about the safety and aspects of making sure a young person, a student, athlete gets the support they need. But we go through our D lines, which is don't ignore your gut, listen for the signs, interact with the person, name the concern. E is for evidence, the concern. S is for supportive environment. Then under supportive environment, we get into the, aspects of implicit unconscious bias as well as microaggressions. And why it's important to do that is it helps students, come to the classroom, to the gym or football field 100%. And so doing that is sort of what we do. And we've done it at Baylor and Stanford. And we've seen some significant results, 41% increase in coaches' comfort level in identifying the signs of mental health challenges, 45% increase in feelings of sufficient suicide prevention training. And the great thing is when we did this at Stanford with about over 200 coaches, 100% of the respondents felt the training was useful in creating an action step to support their students. And some of the qualitative feedback we got was from a white female coach, which she mentioned she would love to hear more support about how they can improve their communication support for athletes as it relating to the inequality of race relations. So that plus, we've had very many more verbatims about how this has helped coaches identify students at risk. But that's a key piece as why we do it and how we plan to expand it across the other universities across the country. And as Martha said, you can get to us through the info@the-defensiveline.org or our names, Chris and Martha, at the-defensiveline.org. So thank you for that question.
Okay, we will include that information in our show notes as well. And thank you so much. That was great, sharing everything that you just did with us about the defensive line. I know in these shows, we don't have a lot of time to get into all the nitty gritty, but that's wonderful that you were able to share that with our listeners. My next question that I have is for Dr. Moutier, which is how do we teach emergency services and primary care the appropriate way to screen for suicide prevention?
Well, I think that's a great question. And I'm assuming this is coming from a mental health clinician who sounds, passionate and wanting their counterparts in other parts of the health system to become, part of the solution in terms of screening and suicide preventive care, which is wonderful. And so I think I'll answer it in sort of two different ways. The first is that a very pragmatic answer, which is, don't assume that they're going to be resistant, and use your relationship, hopefully building trust, between your clinical services. And if let's say you're doing site consults or something like that with those other services, with primary care and emergency departments, they are relying on you then as the expert to help them deepen their work in suicide prevention. So I think, and then the next part is, what resources can you bring to bear? And, just remember, you don't have to have all of the answers. You don't have to do all of the training yourself. You can find those training resources that are maybe even designed for primary care or for emergency medicine to learn screening. And remember, screening on its own is not going to be enough. They do need to learn how to screen and then move on to suicide risk assessment, and then also to understand what are the appropriate care steps, like safety planning, lethal means counseling, caring communications, referrals, and resources and education that can be done in primary care and in the emergency department. There are these brief interventions now that are being implemented. So I would point you to, certainly we at AFSP, through our Project 2025 initiative, have training resources. We've partnered with a group called Suicide Prevention. And this is Tony Pisani's education shop. He was one of the co-authors with myself and Steve Stahl on our suicide prevention handbook. And Tony has created a very user-friendly training module for primary care and also for emergency medicine, so that they can actually implement screening. And again, not just screening, but the whole wraparound suicide prevention, program and approach for patient care.
Wow, that was such great information. Thank you for sharing that with us. And actually, my next question is also for Dr. Moutier. What suggestions do you have for opening up communication about suicide with family members within the health system setting?
Okay, so what I would really recommend for clinicians is to not wait until your patients are in crisis to broach the topic of, which family members can be involved and what the limits are in terms of communication with them. I would even encourage all of us to look into this newer approach that's called the Psychiatric Advance Directive, that teaches clinicians how to broach the topic of what patients would want to see happen in the event of various different people, and in the case of people with chronic mental, that are not only possible, but are kind of likely scenarios to walk through what would they like to see happen, if they were to become more psychotic, or if they were to reach a point of more, suicidal crisis, or really needing to be hospitalized. And when the person is empowered to make those decisions in advance, so again, I'm talking about when they're in a well state of mind, be working with them on what they would like to see happen. That is really the ideal scenario, where you blend the patient's autonomy when they're in a more well frame of mind with those moments in time that then they can realize they've already made those decisions in advance. And back to your question, that can include how they'd like their family members and other loved ones to be involved in their care. And we're not including family members enough in our clinical work with regard to suicide prevention, because remember, they are the ones that are part of our patients' lives 24/7, far more than that, in different and impactful ways than we are as clinicians. And so the ideal would be to be engaging everyone who can play a role in, let's say, making their home environment safer from lethal means, or supporting somebody who is in distress and potentially in suicidal crisis. We at AFSP developed an education program fairly recently that teaches family members and loved ones how to support a person after they've attempted suicide or are just going through a difficult time. It doesn't have to be, that specific scenario, but people who are what we call having lived experience of suicidal thoughts and struggles. And believe it or not, that education to family members is something that is kind of new in the world, because even being an expert or being a clinician where you deal with patients all the time, when it's in your own family, and I can speak from my own experience with this unfortunately on multiple occasions with multiple family members, that it doesn't translate directly to being a clinician or being like a suicide prevention expert to walking the walk in your own home. So just know that kind of education is available for family members through AFSP. You could ask for it. It's a program called Finding Hope.
Oh, that's wonderful. Thank you. Thank you so much. The next question I have is for the Thomases. What would you say to someone who's lost someone to suicide, but is too distraught to talk openly about it or to seek help? Is there advice that you would give to friends of someone who has lost someone to suicide?
So for the first part of the question, to someone who's lost someone to suicide, but is too distraught to talk about it or to seek help, I would say give yourself grace and give yourself time, because it's not going to be easy. And it will take time to be able to talk about it, and to find a support group where they're like-minded people. I know Chris and I and Solomon went to a support group for a few years, and at first we didn't say anything. We just went and listened to other people, and we learned that it was a safe place to talk about what had happened, and that was very important in our journey, to be able to be around people who didn't have judgment about what had happened because they had gone through the same thing. And it was not only it might have been someone who had lost a friend, it might have been someone who had lost a parent, a sibling, a coworker. And it really helped us to come out of our own heads and hearts a little bit and to see that it wasn't just us that was hurting.
Yeah, the only thing I would add is, and like Martha's right, that the support piece is so key in helping us deal with our grief. And key thing I would also mention is it's important to avoid the guilt and shame and woulda, coulda, shoulda scenario, because that could just take you down a dark rabbit hole. And I find also once you get the support and once you get the right grounding, I found it very therapeutic to tell our story, to help. And then we did that. We try to do it in a responsible way by working with folks at AFSP, Dr. Stephanie Rogers and Dr. Jill and Dr. Moutier and the whole team to help us tell our story in a constructive and productive way so that it provided people hope. So I think that's a key piece of it for us individually. And then organizationally, we thought it was important to then share our story so that others can do the same thing and so that we can be, as Christine mentioned, proactive in the communication about addressing the importance of mental wellness. And one of the things we always share in our workshop is we use Desmond Tutu's quote that there comes a point when we have to stop pulling people out of the river. We have to go upstream and find out why they're falling in. So we thought that was a great way of trying to be proactive and providing hope for others by working through schools and universities and corporations and talking about mental health, making sure that it's having that discussion that it's okay to not be okay, and for people to understand that we got to talk about it. We just can't put our head in the sand. And the more we talk about it, the more we normalize the conversation and we remove the stigma. So that we think it takes individual and organizational efforts to do that. And that's a key part of our story, and it's a key part of helping others, go through this as well.
I also had friends that were very helpful to us. I had a friend that would just come over and make a meal and she would leave. I didn't have to talk to her, but it became comfortable to have someone here again, because it wasn't for a while. Or ask them to go for a walk. And don't be afraid to say the person that they lost. Don't be afraid to say their name. I missed people saying Ella's name at first. And so when people did say her name, it almost became, it felt lighter. Like it wasn't like people were afraid to say it. So when they did say it, it felt really good. And then we participated in the overnight walk the first year Ella died, because one of her friends just every week he would text me and say, hey, I'm going to come to Dallas and do the overnight walk. Would you join me? And he said, you don't feel pressure, but I'm going to check on you every week to see if you've changed your mind. And that was really important. It was, again, like-minded people who weren't afraid to talk about suicide. People, our daughter, we were recognized by the beads that we wore, so that was a really important step, a literal step in walking, learning how to walk again.
Oh, I love that. And you're talking about the AFSP walk, right? That's for suicide prevention. Yeah.
And there are community walks from AFSP more often than the overnight walks, but we've participated in the overnight walks. But I think that from what other people have said, they're all very meaningful.
Yes, yes. And there's also the campus walks. And the other thing that Martha just made me think of is it's important to understand that the person who died by suicide's death doesn't define them. And it's important to talk about how they lived their life and to focus on that, and also to say their name, like Martha mentioned. And it's okay to say that I still love Ella. I still love what she did, and to share stories. And that is also so welcoming, because it is important to understand that their death didn't define them.
Right. Absolutely. Well, thank you so much for sharing that. The final question I have for Dr. Moutier is, how can clinicians become more involved in the American Foundation for Suicide Prevention?
Well, thanks for asking that. And certainly our chapter network, across all 50 states and Puerto Rico now, all of them need clinicians to be involved, because most of our volunteers are not clinicians, and the chapter work is incredible that goes on at the community level, putting on our education programs, our loss and healing programs, doing advocacy work at the federal and state levels. But oftentimes the chapter becomes a go-to resource for the community, for, families who are needing help. And so the clinicians joining the work and oftentimes joining the chapter board of directors, it adds incredible value. So please know that there's an AFSP chapter near you that needs you, and you can go to afsp.org. And if you scroll down on our website, you'll see a section that says connect to your local chapter, and you can click to just send them a direct message that way. And I will also just invite any clinician who has ideas and wants to get involved to reach out to me at cmoutier@afsp.org. And if I'm not able to answer, I'll put you in touch with the right person on the AFSP team who can. And I just wanted to say that what Martha and Chris are doing and what they're sharing is really part of this incredible work that's happening in the movement of suicide prevention and postvention, which is that by telling our stories, by becoming more vulnerable and authentic, we can then accelerate the beautiful thing that's happening with the scientific community, focusing on those important research studies that are answering the questions about what drives suicide risk and what constitutes effective prevention. But the science left in a vacuum isn't enough, because it's through our own stories that we are getting the attention of policymakers and getting more funding, and then accelerating the translation of the implementation of that research into real life, programs, clinical interventions, and beyond. And I also want to just say that we know so well that clinicians are human beings too. So we wear multiple hats. We're not just in the clinical lane of suicide prevention. We may also have our own personal experiences of either lived experience or loss. And all of that allows you to become an even richer, deeper resource to the people around you. And I will say that until I got involved with AFSP, I was doing that, but in a limited way, because you're not when you get involved in the work of an organization like the Defensive Line or AFSP, you learn how to live it and breathe it and walk it through and through, so that our lives become less compartmentalized and the work becomes just somehow more freed up. And so I just wanted to kind of explain that if you're a clinician and you're just not sure, what more you can do. Obviously, you're involved in patient care probably, and that feels like enough and a lot, but there is more. And I think it really can augment even your clinical work when you start to get involved in these ways that allow the personal part of this and the advocacy to come to bear. It really is it's like a spiral upward that somehow frees us up. It's quite a remarkable experience.
Yeah. Absolutely. I think it's so powerful what you're sharing and so uplifting. I have a final question for the Thomases as well, which is people want to know, how can they get involved as volunteers for your organization?
Well, first of all, they can do the practical hard work of checking on their family, their friends, their coworkers, and making a genuine connection with them. And then I would also ask people to book us at their jobs or their schools or for their teams to either do a speaking engagement or a workshop. We're always open to doing workshops and public speaking. So that's one thing that's really helpful for us.
Yeah, absolutely.
Excellent.
And if people want to get a hold of us, as Martha mentioned, they can do that with info@thedefensiveline.org or Chris or Martha at thedefensiveline.org. And we're also on social media. It's at The Defensive Line for Instagram, Facebook, LinkedIn, and YouTube, and at T Defensive Line for Twitter. But yeah, we think, as Dr. Moutier just mentioned, if we could work this together as a scientific community, as individual human beings, as family members, as people like Solomon and Dak leverage their platform to share the story, and the importance of making sure we're authentically checking in on each other, making sure that everybody's okay. And if they're not, to listen compassionately, that goes a long way in helping all of us get through the days that sometimes are hard to get through. And one of the things we've learned throughout this journey is that significantly suicide impacts so many others. And as we share our story, the number of times someone else talks about how someone they even knew, or directly or indirectly, that they've also been touched by suicide. And by having that conversation, we just help each other out, and we help people normalize the conversation. And, this type of program goes a long way, but we would love to help, corporations, universities, and independent school districts, understand the warning signs and how they can help create supportive environments for their communities and their families and their organizations. So we would love to be able to help out as much as possible.
That's great. Well, I just wanted to let everyone who's listening here know that, I think one of the reasons that you all received a standing ovation is because this presentation was truly unique. We have definitely talked about suicide before. We've definitely addressed these different issues, but I feel like in this presentation, you gave people a reason to hope. And that was the title. It was called Reasons to Hope: Evidence-Based Actions for Suicide Prevention. And with that, I would just like to thank all of you so much for your incredible work with suicide prevention. We have come such a long way now with the science and, just people being more active in the community. And I just want to thank each of you for the powerful role that you're playing. It's truly making a difference. So thank you.
Thank you, Sabrina.
Appreciate it.
Thank you. Yep. It's such a pleasure getting the opportunity to work together in these ways. And NEI is doing such wonderful work in this regard as well. So thank you.
Amen. Amen.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.